whenever you're ready, we'll get going. All right. Good evening, everyone. Welcome to the April 9th New York City REMAC meeting. We'll start by taking a roll call attendance. You can hear me, Charlie, right? Okay, good. We'll start with a roll call attendance. Michelle.
We'll call your name, please say present. Robert Winchell, Joseph Schenker,
Here.
Michael Batch, Robert Ackerman, Laura Ivagoli, Stuart Kessler, Matthew Fink, Wallace Carter, Eric Cohen, Kelly Gorman, present, Kevin Munjal, Cindy Basilios, Grace Cacciola, here, Dario Gonzalez, here, Glenn Aceda,
Here.
Bradley Kaufman,
Here.
Nathan Reisman,
Here.
Pamela Lai, here, Nicholas Alexandru,
Here.
Doug Isaacs,
Here.
Kevin Ward,
Here.
Anne Marie Trudenti, here, Andrew Dahl, Allison Burke, Jeffrey Raybridge, Lauren Costerco, Rick Caldwell, or Jonathan Berkowitz, Louis Marshall, Michael Redlener, Dominic Bettinelli, Ethan Rendon, Eric Lutinger, Paul Barber,
Present.
David Benelli,
Yes.
Mary Foote, Mark Cantor,
Here.
Ed Jarvis,
Yeah.
Joseph Bowe,
Here.
John Graves,
Here.
Jessica Van Voorhees, Benjamin Zabar,
Yeah.
Matthew Harris, Robert Krupe,
Here.
Arthur Cooper, Yadidya Langsam, Anthony Shalish,
All right. Thank you. So we do have a quorum, so we can begin the meeting. First, I will entertain a motion to approve the minutes from the January 23rd meeting. Those minutes were sent out for review. If anybody have any questions, comments, concerns? Seeing none, could we take a motion to approve the minutes? So moved. Second, thank you. Okay, the minutes will be approved as is. Next, the correspondence report. So I will read them into the minutes. Give me a second to find them. Here we go. Okay. DOH enforcements. Mackenzie Nickel of Baldwinsville, New York. EMT number 441429 is suspended for 3 years effective 3/4/24 for violations of a lot of things. Suspension is stayed pending successful completion of a 3-year probation, and that provider was assessed a civil penalty of $12,000, $10,000 stayed pending successful completion of probation. Amanda Teamstit Obelt from Salisbury Mills, New York, EMT number 474737, suspended for 1 year effective 3/11/24 for violations as stated. Suspension is stayed, 3 years probation effective 3/11/24, and a civil penalty of $1,000, 500 suspended pending probation. Jeffrey Ashtown of Modena, New York, 346727 is surrendered effective 3/7/24. Ryan Gittens of Brooklyn, New York, EMT number 419796 is suspended for 1 year effective 3/18/24 for a bunch of violations, assessed a civil penalty of $2,000. Arnaldo Adeliz of Brooklyn, New York, EMT number 477062 is revoked effective 3/18/24 for violations of something. Assessed a civil penalty of $5,000. Leah Casino of Staten Island, New York, EMT number 361718 is suspended for 1 year effective 1/11/24 for violations. The suspension is stayed on probation for 3 years effective 1/11/24 and assessed a civil penalty of $2,000, of which $1,000 is stayed. There's a lot of people causing problems this year, this week, month, whatever. Stephanie Lugo of Bronx, New York, 361718 is revoked effective 8/17/22 for a bunch of violations. Stanford Fire Company #1 of Stanfordville, New York, surrendered effective 1/9/24 for violations of Article 30. And these enforcement actions can be viewed on the DOH website, and will also be written into the minutes when we go through the full minutes. A CDC advisory about invasive cerebral Y meningococcal disease was received. CME trainings, let's see, this was on May 8th. This is coming on May 8th. The Mount Sinai Center for Healthcare Readiness, the Future of Healthcare Readiness Conference on May 8th, 2024 from 10:30 to 5 at Mount Sinai. The fee will be $85, and the registration website will be posted for all to see. NYP Queens and Bayside Glen Oaks Volunteer Ambulance Corps will host a chest trauma call review on April 30th from 7 to 9 via Zoom. You must register via the Glen Oaks Volunteer Ambulance website, and that will be 2 hours of CME and 2 hours of call review. Okay. We also got a correspondence from the Bureau of EMS about the EMS rewards. Nominations are being accepted now. This was emailed out to everyone. EMS Innovation Awards and EMS Recognition Awards for the 2024 EMS Week reward thing. Yeah, at the annual
Ceremony. It's a called ceremony.
Thank you for that word. All right. Any questions on that correspondence? Okay. Hearing none. Just for the record, Dr. Redlener walked in. I believe he's here.
Yeah.
He's there. Okay. And Dr. Ravitch, who walked out, is still here, but he walked out. He'll be back. Okay. The executive committee did not meet since our last meeting, so we'll begin with our subcommittee reports. Dr. Barbara, CNC.
The Certification and Convention Committee met on April 8th. April 5th, sorry, thank you, April 5th. Topics of discussion included we're thankful that the physician medical control credentialing and re-credentialing appears to be live. Several in-services have been completed for any instructors or faculty members that, to onboard new providers, but I urge all physicians who have active medical control credentials prior to the September 30th extension deadline, go on the website, make yourself a collaboration link, sign up, and start the process with renewing your medical control. Last in the alphabet, but first in our hearts, Jason Zimmerman already completed the process first, and he was the first official physician to complete the process online. We were in the middle of discussing ongoing credentialing and CME topics, and the meeting was abruptly ceased on April 5th at 10:29 a.m. for global reasons. That ends the report. Just Google it. There was a big shaky thing that happened.
Okay. Again, for the record, Dr. Ravitch is now in the room, and Dr. Caldwell is here as well. Reed Caldwell. Okay. Any questions for Dr. Barbara on the CNC report? Any questions on earthquake for Dr. Barbara? How about snake bite?
Is Staten Island an earthquake center?
Yeah, are you at an earthquake center in Staten Island?
Level 1?
All right.
There was an ongoing topic from recent meetings.
He's not enjoying our comments.
It wasn't, but it's an appropriate question. Yeah, I think. Having the most bridges of any borough and geographic isolation from the mainland, I would say Staten Island is probably not well suited as an earthquake center. Thank you.
Are you sure you have more bridges that can happen?
Anyway, we'd like to open a discussion about the requirements for medical control physician re-credentialing. This will be a topic we bring up at the next REMAC meeting. If you have any concerns about the process regarding merit badge courses and board certification, that'll be something that could be implemented on the LMS, but has to be voted on here. I will bring a report for the next meeting on what the existing process is, so we can discuss modifications.
So I guess we'll have a brief discussion on that. Is there anybody here who would like to give Dr. Barber any feedback on physician qualifications or what they should have in order to be credentialed as an online medical control physician? Obviously, you can all attend the CNC, but if anybody has anything they want to mention, yeah, go ahead. You guys need to go microphone. Yeah, but it's not close enough to you, Gary.
But my concern is that we make it so stringent.
Just move it closer. Somebody, please.
Or yeah.
There we go. No, we found one for you. The way it should be. Now you just turned it off.
Oh, come on, stop this shit. All right.
Dr. Gonzalez, please continue. I'll repeat. what you
Mike,
say.
no, come on. It's serious.
I'm dead
No,
serious.
You guys
Why
want
don't
to play
just-
fucking games, let's go home. But my concern is, and I've been thinking about it, is that you have to be careful that we keep applying more and more qualifications, more and more barriers. And in the end, we lock out people that we should be using. If that's the case, then everybody here can start getting ready to go to telemetry. You all want telemetry, but you want to knock out a lot of people. So be very careful how you do it. I'm not into a debate now, but I want people to consider what they're doing, because we get caught up on our own. Well, I'm a diplomat. I got boards. I got all this crap. That doesn't make a hell of a difference, but we can't get somebody.
Right.
All right. And now I'm not here to debate the whole issue, but I would just want to make that statement. All right. Think about what we're doing. And I think we all should think about that. Do we need qualified people? Yeah. But don't make it so tough that no one can do it. And then we'll just have to not have telemetry. Unless you want to start filling in some of those spots.
Very good point.
Can I just?
Yeah.
The purpose is to.
No, I don't.
No, it's not a debate, Dario, but the purpose is to actually reduce the difficulty. There's an agreement with you. So the point is to take away the requirements for all the additional courses to make it easier for people to continue the process so that telemetry can be staffed without creating additional obstacles. As it stands, there are more obstacles for people who are not board certified to be able to do telemetry shifts. And that's what we're trying to change.
So do we need to vote on this now? I mean,
No, it's not even discussed yet. This is just feedback for.
I'll present it at the
Make
next
it-
meeting.
Yeah.
Yeah.
That's what I'm saying.
Because
I
we
don't-
took board up at medical standards already and
Uh-huh.
approved the report to here for discussion and approval.
So,
Ben's goes.
so you're saying medical standards already.
Already discussed this,
Okay,
yes.
so then we'll have it as a vote when it comes up. Yes.
Second in motion.
To Dario's point, and I don't remember if it was at the last REMAC or last Michael Standards, we sort of went from a discussion of, the cost of the exam for physicians, and I guess that's set by the REMSCO rather than the REMAC. And, I understand the financial implication of changing that, but talking about the financial cost in the next, minute, we switched and said, we need to find a way to get more people as medical control physicians to, potentially have more medical control sites. So I think those two are very linked when we're talking about, barriers or whether we're trying to, get more docs. We should try to make things easier while maintaining the standard and the cost as part of that.
In good shape now.
Okay. Anyone else? Well, I guess if it was discussing medical standards, let's wait for the medical standard report. Paul, anything else from CNC?
Negative.
Okay. Yes. Oh, great. Dr. Cooper's here and Dr. Caldwell, I think I mentioned him already, and Dr. Ivacola are all here. Yeah, but we have to save it on the record. So, all right. Dr. Benelli, medical standards.
Okay, good evening, everyone. Medical standards, this is a combination of two medical standards meetings. One that we did not discuss during last REMAC when we didn't have a quorum, and the one that we just had last week. I'll start with we'll go chronologically from the previous medical standards meeting. So the first thing that was brought up for discussion and discussed extensively in medical standards, and then later on also unofficially in this smaller forum when there was no quorum, was regarding the MOST advisory, the updated MOST advisory. with, and the recommendation of medical standards is to issue an advisory with recommendation to take the New York State LMS. Morty Lax, the head of training and education, reviewed that training module and says that it is still appropriate, even with the update, to change from present to available. It is still a good training module to be used. There was an extensive discussion whether we can really enforce it for BLS providers and for certified first responders. And we felt that this would be an undertaking that would be hard to enforce, and therefore we recommend that we issue the advisory updating with the New York State Department of Health Advisory 23-12 with the updates that were included in it, and strongly recommend that each provider devotes the time to do the LMS training. So that's what is the second in motion over here for discussion.
Any discussion on that point? Yeah. Okay, hearing none, we'll vote.
Say in favor, opposed, or abstaining. Want to say that?
Right, this is to make it a recommendation.
Recommendation, not a requirement, that we do training using the state LMS.
Yes.
Bradley Kaufman,
Yes.
Dario Gonzalez,
Yes.
Nathan Reisman,
Yes.
Pamela Wise,
Yes.
Nicholas Alexander.
Yes.
Doug Isaacs.
Yes.
Jeffrey Raybridge.
Yes.
Reed Caldwell.
Yeah.
Louis Marshall. Michael Redlener,
Yes.
Joseph Shanker,
Yes.
Joseph Bowe,
Yes.
Arthur Cooper,
Yes.
Robert Winchell, Ed Jarvis, Mark Cantor,
Yes.
Robert Krupe,
Yes.
Mary Foote, Laura Iapoli. Yes. Matthew Pink, Kevin Mangel, Sidney Basilios, Matthew Harris, Jessica Van Voorhees, Benjamin Zabar,
In favor.
Paul Barber,
In favor.
David Benelli.
Yes.
Is that a yes?
Yes.
Eric Buttinger. It's unanimous.
Thank you. All right, Dr.
Thank you.
Benelli.
The next discussion was for online medical control physician, was from a report, was motion that was brought from CNC for discussion at medical standards with the proposal that physicians who are online medical control physicians who are recredentialing, not their initial credentialing, but their recredentialing for the online medical control physician position, and they are not board certified, we will remove the requirement for them to have ACLS, PAS, BLS, etc., ATLS from the
All of the
requirement-
above or just?
all of the above.
If they've already got a card and
Oh.
they're certed, they're going through the medical control process, doesn't require them to have active
Got
active resuscitation merit badge cards.
Got it.
Because they're doing a CME based refresher on the LMS.
Understood.
And they're updated with the current ATLS, ACLS, etc. by virtue of doing the updates. So this was approved in the Medical Standards Committee and is brought over here as second in motion for approval.
Excellent. Any discussion? Yes.
Does that affect the REMAC, like for the community paramedicine folks, right? Because they're not doing ATLS. Does that just grandfather them into? Because I don't want that.
Talking about the telemedicine physician component, that is not actively being credentialed on the LMS at this time. This is just OLM's medical control. The REMAC telemedicine component is yet to be added into the learning management system for credentialing.
I think that Glenn's question though is bigger. If the credential requirement for both becomes the same, Are we basically watering down and making those telemedicine physicians essentially the same as online medical control physicians? If the requirements are exactly the same, why aren't they getting a full online medical control card? Or you're just saying that just because it's just for refresher,
Yeah.
is why that's okay?
This is an existing provider who's refreshing, who has an active practice in medical control in this region. They would not need ACLS, BLS, PALS, and ATLS codes
So they
because they've
would
already
need-
been onboarded
Right, so
And
they
they're-
would need to be a full online medical control physician.
with an,
already refreshing.
with an active practice, they're refreshing.
Got it. So
But right now, the light part, though, aren't they currently certified? For community paramedics. We did not require them to have the ATLS and the PALS, and their argument was because
They didn't need it.
our folks at home based, right, they're all adults.
Yeah.
And so we let them have that, but that was a little concerning because when they came through telemetry, our telemetry to rotate, we had no idea who they were. And, you know, the cards they got were the same, but we don't want the telehealth community paramedicine doctor giving orders to a 911 paramedic. So there's gotta be some kind of a differentiation, but the way you're making it sound, I think, is that they'd be able to get recertified the same way, but that can't be.
No, I want to go back to the original. The REMAC telemedicine physicians are not credentialed in this fashion at this time.
Right, but
Since we transitioned to the learning management system for the paramedics, and now this, we are not absorbing the REMAC telemedicine physicians re-credentialing through this process. They're being done the old-fashioned way via paper.
correct, but meaning the requirements for credentialing, whether you're on paper or via the LMS, if they're identical for both. So I think what we have to clarify is that this is only for refreshing a full online medical control physician.
Yes, and in the New York City REMAC ALS requirements, which the REMAC requirements for the provision of ALS care, online medical control is its own section compared to REMAC telemedicine physician. And we're only modifying the section relative to the online medical control physician
Fine.
to maintain a lack of dilution and enhance someone who has an active practice to recertify without having to sit through 3 days of ACLS, BLS, PALS, and ATLS, because anything that's relevant updates in those criteria, we're going to be brought here in our protocols anyway, and they're absorbed in protocol updates because of the learning management system.
Good.
Does that make sense, Glenn?
It's already incorporated. No need for a separate merit badge.
No set need for a separate merit badge, because anything that's in the ACLS programs is going to come through our protocols, and the physicians are going to be required to do protocol updates.
So to be clear, the motion that's coming forward only applies to somebody who has
Well,
a
I'm
full online medical control physician certificate. And that when they are renewing, they do not need a new ACLS, PALS, and ATLS. However, if you're an online telemedicine physician, you would need, that this does not apply to you.
We haven't had the bandwidth to absorb the telemedicine physicians on the LMS yet,
Okay.
and we'll look for a stakeholder and leadership when that time comes. But this is like medical control in the original sense of the term.
I think that answers the question.
Understand what they do. Can't have them give directions. to paramedics.
They don't meet those qualifications.
No.
All right.
No, I think the motion is clear that it only applies to full online medical control physician. Okay,
Joe has.
Joe.
Dr. Seda, just to be clear, the idea is that in order for you to get the OLMC certification the first time around, you need to have the card. So you have to go through it the first time to get the credentials. And then the idea is, as opposed to you having to take the AHA courses again to renew, when you renew your OLMC, you're going to get those same updates through the protocol updates. So that's why we're proposing to remove that, because the idea is that if you're going to sit through our protocol updates, if there are any changes in the ECC guidelines, we've always covered them very extensively through the protocol updates. Why make you also sit through 3 or 4 separate classes when you've been giving orders as a physician? You've been running codes over the phone with the medics during that time. If a telemedicine physician wants to transition to become OLMC, that's the same as someone that's doing it new. They would still have to get that initial credentialing. So they still have to get the initial credentialing, the AHA credentials for the first time. They just don't, we're just not requiring them to maintain the certifications. That's the proposal.
This is not meant to muddy the waters between a telemedicine physician and a medical control physician. It's actually to remove a financial and a timing obstacle from medical control physicians maintaining their practice.
Any other questions? All right, so then I'm gonna restate the motion how I understand it, and you'll let me know. Michelle's gonna write this down, see if this makes sense. For renewal of an online medical control physician, they will not be required to have a current ATLS, PALS, and ATLS certificate. Is that correct?
Yes.
Okay, only for renewal of a full online medical control visit. ATLS, PALS, and ACLS. And BCLS. I think. Okay, so that is the motion. And Michelle will take us through a roll call for all in favor or opposed.
Michael, in favor, oppose or abstain. Glenn Aceda,
In favor.
Riley Kaufman,
In favor.
Gonzalez. Nathan Reisman,
Yes.
Pamela Lai,
Yes.
Nicholas Alexander.
Yes.
Doug Isaacs. Jeffrey Raybridge,
Yes.
Reed Caldwell.
Yes.
Louis Marshall. Michael Redlener,
Yes.
Joseph Bowe.
Yes.
Arthur Cooper.
Yes.
Robert Winchell. Ed Jarvis. Mark Cantor. Robert Krupe.
Yes.
Mary Foote. Laura Iavicoli. Yes. Matthew Fink. Kevin Monjal. Cindy Basilios. Yeah. Matthew Harris. Jessica Van Voorhees. Benjamin Zabar.
In favor.
Paul Barber.
In favor.
Yes.
David Benelli. Eric Luttinger. Motion carries.
Thank you. All right, Dr. Benelli, back to you.
Okay, then there was discussion, which needs to be brought for discussion in REMAC and, possibly the REMSCO, Board of Directors regarding prorating the cost of all these, credentialing, et cetera, to a 3-year cycle as opposed to what it was previously, so it will be the same. So that is something that, we need to discuss, but I think it makes sense not to, incur additional charges because we now move to a 3-year cycle.
All right, so the current charge for an online medical control physician to renew their certification is $200. I think, and that certificate was valid for 5 years. Now that we've gone to a 3-year cycle, I think the idea is that we should prorate that cost so that it is now equal essentially to what a 3-year cycle should cost. That is what's up for discussion. Any opinions on this? Anybody want to say anything? Both the physicians and the non-physicians in the room, because they have a charge as well, and their charge didn't change when we switched it. All right, nobody cares?
Hello.
All right,
I mean,
go ahead.
I think I said it before, but I think I'm in favor. I mean, it should be equivalent, per year. That makes sense. We should make it harder.
Got it. Anybody else?
Yeah, Marie wants to say something. Can you hear me?
120 is an odd number.
Okay.
Just leave it at that.
Oh, okay.
I need her on.
Hello? Oh, well. Doesn't matter. Not gonna happen. Hello?
We could do is recommend it. It's 40.
Marie, 1 sec. Let me.
Hello?
Hello, Marie. Can you hear me?
Okay. You could hear me now?
Hang on. Let me. You're not set up for the meeting to hear you because I wasn't aware to make this hybrid.
Oh, you know what? Don't even worry about it. I'll deal with this offline.
You sure? Hooking up
Yeah.
now.
No, I'm not gonna deal with them tonight. I'll deal
No?
with it later.
Later.
Thanks.
Okay. Sure thing.
Anyone else? I know Marie wanted to say something. Did she let anybody know what she wants to say? Oh, got it. Again, I don't think that the REMAC isn't the one deciding on this number. This is decided by the REMSCO board. But I do think that the REMAC can recommend to the board that we do prorate it. I think that, 120 is kind of odd, but maybe $150 for the 3-year cycle as opposed to 200 is a fair number. Any other questions on that? I don't know that we necessarily need to vote on this, but I think we can recommend that to the board. We can show a hands vote for everybody would be fine. So all in favor of making a recommendation to the board, that we change the price for 3-year cycle to 150 from the 200, please raise your hand. Anybody opposed? One opposed. Any abstentions? Okay.
Can I just comment?
Sure.
That the reason I'm opposing it is because I want it to be the 120, not the 150. So that would be my recommendation. To prorate it to the proper amount.
I will definitely forward that to Marie and to the board. Okay, David, back to you.
There was also a discussion that we need additional online medical control facilities with the closure of some online medical control facilities and others. There is a need. The current online medical control facilities are overwhelmed, and there was a call to facilities, services, EMS services, to agencies to consider creating online medical control facilities. There was also a request from medical standards to review the BLS protocols to see where medical control options can be removed in order to lessen OLMC burden, but there really are not that many BLS medical control options. So that's something that can be reviewed in protocol. I don't think that will change much with regard to the burdens on online medical control. That concludes the March medical standards meeting. Now we'll go to the meeting that was last week.
David,
Yes, sir.
just can you speak a little bit more to the online medical control request to other facilities?
So we got input from I believe from MAMO and maybe from other online medical control that facilities that they cannot absorb the void that was left with closure of a couple of online medical control facilities. I believe it's not only Staten Island, it was another Methodist.
So Maimonides
yes.
basically took over all of the private volunteers, everybody that Methodist was providing medical control for. And it has overwhelmed them. They feel that it is a burden that they can't manage alone. There has been some discussion at the REMAC, at the regional, in the office, to possibly put together a REMSCO online medical control facility that would be virtual, but with a recorded line, and the burden would be shared amongst all of us to take a shift essentially where it would get forwarded to your cell phone and you'd be able to, on a recorded line, provide online medical control. That has been discussed, and it, I think, is a viable possible option. Marie would like to pay the physicians that are working. Obviously, we don't have the budget for that right now, but it is something that we probably do need to consider, considering there are volunteers and BLS agencies primarily that do not have any access to medical control just because there's not enough resources out there. And the burden can't fall on the fire department. So Glenn, don't worry. I will be sure that it doesn't fall on you. The burden can't fall on the fire department to do this work. So that is something that we've been looking into. Joe and Scott are looking into the technology component of it. And if we can get that up and running, then we will start nagging all of you to see if you can help out by covering virtually for online medical control. Not the fire department. You guys do enough. I'm just saying the rest of us could probably help out.
The pay is greater than the fire department.
I mean, if I give you $3, it's better than the fire department. I understand. Again, so that is definitely something we're looking at. Right?
What's the scope of the problem? Like, do you know about how many calls a day these volunteers are?
I know roughly, but it's, again, the Methodist was seeing about 5,000 to 6,000 calls a year. Between Hatsola and the volunteers.
Hatsola
it was-
alone
it
probably
was,
was-
that was the volume that we were seeing at Methodist. Now that, a lot of it was absorbed by MIMO, but even with MIMO absorbing, there are a lot of agencies that were not able to get on boarded with MIMO because they're just overwhelmed. So there are a handful of agencies. I don't think there are very many ALS agencies. I don't think there are any actually ALS agencies. There's a lot of BLS agencies that are short. And those really don't have significant volumes. An RMA here or there, EpiPen usage. We're not talking about significant high-risk call volume. We're talking about very mild stuff, minimal stuff that could probably be managed on a regional level, but we do need to have that infrastructure in place. So Reed and then Daria.
What's the timeline or next steps on the?
So Joe and Scott were looking into a way to record these calls and then transfer the phone lines. There might be some in-house technology that they could use versus having to get a system in place. We're hoping that within the next few months, we'll have an answer. Weeks, even better. Daria.
Speak up, you can't even hear.
Controlled substances involved in this?
So this is not significant. I mean, the ALS agencies, pretty much all of them, I believe, have online medical control right now. It's the BLS agencies that are
We
down.
get a sort of a summary report of what numbers we're looking at.
Sure, we could put that together. Anybody else? All right, so again, I hope to have more information for you, I guess, at the June meeting, because there is none in May. But I hope to have more information for you shortly. Go ahead.
Okay, so now we're moving to medical standards. That was last
Part
week.
two.
Part two. Yep, so there are a couple of protocols that are being brought forward for discussion, and then there's a report from the ultrasound tag. I'm gonna allow Dr. Lai to present these protocols, these changes to the protocols. There's a change to an appendix, to a GOP, and then there are the rescue task force protocols. So Dr. Lai.
Okay, so this first change to the appendix, so this is for the do not resuscitate and the essentially the most appendix. So this change was brought forward to medical standards for the February 6th meeting. That was held virtually, and this is what was discussed. Essentially, you know, just to be able to better encapsulate any the changes that we see now with the state policy in terms of with healthcare agents, as well as to make this a little bit to be able to keep this both simplified for our providers, but then also to be able to keep this more current. We have just simplified this appendix so that instead of having our own language in the appendix, you can see that it is now all struck through. And instead that there is a statement that replaces it to in essence to say that that we are going to be following the New York State policy, or its updated replacement. And for the PDF version of these protocols that are going to be put forward, there will be a live link to the current New York State policy for this. So that is the changes coming forward for this protocol or for this appendix.
Any questions on this? I mean, we actually have talked about this multiple times, but this is the final language. So. And I think, again, this is consistent with what is happening already and is already approved by the state.
Now,
Any
this
questions?
does not have to be brought to
don't-
CMAC. It's
so
an
I've-
appendix, right?
So, yeah, Jeff and I were just looking, I don't think any of the changes, there's maybe one change in all the protocols that are coming forward that would have to go to CMAC. I think most of it is language stuff and not CMAC necessary. All right, let's vote on, you want to vote on this one by itself?
It's up to you.
I mean, is there anything we can tie it together with?
So this is a standalone. The other one that we have is the change for the GOP regarding the.
Let's do those together. Oh, that's the oxygen one. Right?
Yeah,
Yeah.
they're separate, totally separate.
So let's do it separately, fine. So this, we're gonna vote on the appendix C.
All your name, please state in favor, oppose, or abstain. Glenn Zeta,
In favor.
Bradley Kaufman,
In favor.
Dario Gonzalez,
In favor.
Nathan Reisman,
In favor.
Pamela Lai,
Yes.
Nicholas Alexander.
Yes.
Doug Isaacs. Jeffrey Raybridge,
In favor.
Reed Caldwell,
In favor.
Louis Marshall, Michael Redlener,
Favor.
Joseph Bo,
Yes.
Arthur Cooper,
Yes.
Robert Winchell, Ed Jarvis, Mark Cantor,
Yes.
Robert Groupie,
In favor.
Mary Foot, Laura Ibacoli, Matthew Fink, Kevin Manjal, Cindy Basilios. Yeah. Matthew Harris, Jessica Van Voorhees, Benjamin Zabar,
In favor.
Paul Barber,
In favor.
David Ben Allen,
Yes,
Eric Blutinger. Motion carries.
Thank you. Dr. Benelli.
okay, the next changes to the GOP section. I'll allow Dr. Lai to present that.
So the next change is, just as what, David mentioned, is to the GOP. And I think this was brought forward from the last medical standards meeting, that was just a few weeks ago, where where at protocol committee, we had discussed, the issue of, changing the minimum criteria for the application of, for oxygen therapy, for patients. There has been a lot of research, that was done, on this by protocol committee members. So what is brought forward is that the change so that the minimum criteria that patients are to be applied oxygen for will be to maintain an oxygen saturation of at least 92%. This is consistent with the HA recommendations as well as those brought forward by ILCOR, as well as a lot of literature that is out there. This is also consistent with what is currently in the New York State collaborative protocol.
Yes.
Okay, any questions on this? Again, I think the literature supports it. I don't really know that there's much to discuss. All right, seeing none, we will vote. This is a GOP.
And again, this will not be brought to CMAC.
Correct.
Yes. Yep. GOP doesn't have to go.
When I say your name, please say in favor, oppose, or abstain. Glenn Zeta,
In favor.
Yeah.
We're not doing anything. Fine.
Bradley Kaufman,
In favor.
Dario Gonzalez,
In favor.
Nathan Rice,
Yes.
Pamela Lai,
Yes.
Nicholas Alexander.
Yes.
Doug Isaacs. Jeffrey Raybridge,
In favor.
Reed Caldwell,
In favor.
Louis Marshall, Michael Redlener,
Favor.
Joseph Bo.
Yes.
Arthur Cooper,
Yes.
Robert Winchell, Ed Jarvis, Mark Cantor,
Yes.
Robert Groupie,
In favor.
Mary Foot, Laura Ibacoli, Matthew King, Kevin Manjal, Cindy Basilios. Yeah. Matthew Harris, Jessica Van Voorhees, Benjamin Zabar,
Favor.
Paul Barber,
In favor.
David Ben Allen,
He did.
Eric Blutinger. Motion carries.
Thank you. Okay, Dr. Lai, let's continue with the last protocol. and-
So the next protocols that are being sorry, Dr. Lai. The next protocols that are being brought in, that are being brought for a second and motion from the Medical Standards Committee are the Rescue Task Force protocols. that have been, there's some changes, and I'm gonna ask Dr. Kaufman to quickly go through them so we can all be on the same page. Just to remind everyone, rescue task force protocols are for specialty trained EMTs and paramedics in the New York City Fire Department for cases of mass shootings, active shooter scenarios, where we want to try to get into, maybe not to get into the hot zone where the active shooter actually is, but into the warm zone. So this is for a situation where the scene is not completely under control yet, but bring healthcare providers into a zone that is not in direct fire in order to try to save lives, to stop the bleeding, as we all know. So Dr. Kaufman.
Thank you.
There are just a few modifications to our current protocols, which are currently active, so I can go through those. The protocols start with the general purpose and scope, where there was really just some wording changes and some changes to the list of medical equipment to be consistent with what's currently carried. And then the second page is the standard approach to the warm zone patient. The major changes here is the addition of the NPA and to place the patient in recovery position, both of which have become stressed as part of TCCC and TECC. So we are working to be consistent with those. There's some other.
And the thought behind that is that these are patients that we might actually be leaving, put in the NPA, put them in recovery position and run off and take care of other patients. So it's necessary to try to make sure that they're, to stabilize them as much as possible. Continue, Brad, sorry.
Sure. Just some other wording changes. And then there are 4 sub protocols. There were 3 before, and the addition of the 4th extended care protocol. So the hemorrhage control just adds an additional step that says if bleeding continues despite the application of a second tourniquet, to apply a hemostatic dressing to pack the wound in an attempt to stop the bleeding. The second sub protocol is warm zone triage. Really, this is just wording changes, where this is a separate triage than we would use in a cold zone. That hasn't changed, where patients are either considered alive, red, or black tagged. Patient extraction protocol, again, is just wording changes. It was just cleaned up. No major medical changes there. And this is the new sub protocol for extended care. So again, the goal of the team and of the protocols up to this point is really to get the patients out as fast as possible. But taking into account any possible situation, we hope this would hopefully never occur, where either because of tactical reasons or because of the volume of patients, where patients cannot be removed quickly. And this would allow additional care to be provided by the team. So the first paragraph just stressed that this is not the main goal of these protocols, which is to get the patients out. But if for some reason they cannot, and there is requirement for extended care, this goes through a number of steps that would be expected of the EMTs and the medics. It does require some additional equipment, which we list as well. So I'll show you that here. This does also allow some paramedic steps, which allows for tourniquet conversion and administration of pain medication, fentanyl, as well as some physician steps, which allow, again, for tourniquet conversion or removal and decompression of a tension pneumothorax using a finger thoracostomy. So this is the list of additional equipment that would be required to be brought in that hopefully extremely rare event when we would have to use this extended care protocol.
Okay, thank you, Dr. Kaufman. So really this extended care protocol is like a doomsday protocol that hopefully we would never want to have to use. But it's for these kind of scenarios like the Bataclan incident in Paris, where patients might be stranded for hours. So it's much more difficult to try to extract patients or extricate patients, who are non-mobile. It's easier to bring additional healthcare providers into this kind of scenario and provide additional care. And that's the thought behind this extended care protocol. Again, the goal is always to take out the patient if you really can, but if not, at least we can start to stabilize them a little further inside the warm zone.
So just for clarification, I do believe in looking at these changes that if anything, only the extended care protocol would need state approval. The rest all seems more like language changes. And I think that the extended care protocol, because there's an OMA physician there at all times, is essentially a medical control protocol.
Medical
So
control only.
I think that for the purpose of being transparent with the state, we should send it up, but I don't know that it necessarily needs to go up.
Yeah, I think the only other piece is that the physician part of that protocol is really informational only because obviously we don't regulate what physicians do. Yeah.
Ben,
I just clarify what you just said. The extended care portion, it's not required that a physician be there for it. There's a, Brad, I don't know if you want to go down.
well, it has to be authored. It says right on the top.
Right,
It must be authorized. So it's essentially
Just
medical
the-
control.
I think just this protocol is only
okay.
is new or different. right?
Yeah,
But
Paul.
the NPA and the
Yeah,
physician.
yeah.
I
Would
don't care.
non-rescue
Just-
providers be
Yeah.
expected to provide extended care therapy? No, right?
Wait,
This-
sorry, non-rescue, like non-rescue paramedics?
Yeah. This protocol doesn't apply to them.
This,
right?
this,
Only
just
the-
to recap,
applies to the
because this is an
rescue
extended care,
task
this is
No.
only rescue providers with special training in a warm zone.
Exactly.
Fine.
When you
Yeah.
think rescue, just to be clear though, we're
It's
talking
not
about
rescue, it's anyone who's trained
Rescue
in
task
in rescue task force.
Right.
I understand the confusion between rescue medic and rescue task force, but
But the protocol requires additional training. It's not just anyone can do it.
So
This-
yeah.
This
if
is
you go
gonna
to
be
the-
an
the very
agency-specific
top,
protocol.
You go up to the very top of the protocols.
just like.
So
an
these-
EC protocol, like
Fine.
hashtag protocol. like-
So yeah, I think the scope right at the beginning, only everything in these protocols are only for specially trained providers.
Yep.
In that particular environment.
I think that clarifies it. Any questions on that? All right, let's vote on the rescue task force updates as a whole. And whenever you're ready, Michelle.
When I call your name, please say in favor, oppose, or abstain. Glenn Aceda,
In favor.
Bradley Kaufman,
Favor.
Terry Gonzalez,
In favor.
Nathan Reisman,
Favor.
Pamela Lai,
Yes.
Nicholas Alexander, Doug Isaacs,
In favor.
Jeffrey Raybridge,
In favor.
Reed Caldwell,
In favor.
Louis Marshall, Michael Redlener,
Favor.
Joseph Bowe,
Yes.
Arthur Cooper,
Yes.
Robert Winchell, Ed Jarvis, Mark Cantor.
Yes.
Robert Groupie,
In favor.
Mary Foote, Laura Ivacoli, Matthew Fink, Kevin Majel, Cindy Basilios. Matthew Harris, Jessica Van Voorhees, Benjamin Zabor,
favor.
Paul Barber,
In favor.
David Benelli,
Yes.
Eric Luttinger. Motion carries.
Thank you, and special thank you to Doctors Zaber and Kaufman for putting a lot of work into creating these protocols and updating them. The last item is what Dr. Lai just brought up to the put up on the screen right now. That's the ultrasound tag report that was brought to the last medical standards. The bottom line, Dr. Zimmerman is not here. Dr. Isaacs, do you want to discuss this or do you want me just to summarize it?
It was the letter there.
Yes, this is.
Oh, so really just talks about, especially nationally, we see a lot of EMS agencies incorporating pre-school. See a lot of agencies and systems are incorporating ultrasound as part of pre-hospital point of care, right? Point of care ultrasound. So it's discussion whether this body really has the purview, the oversight of it, as being diagnostics, not a treatment tool per se. But we discussed as a region is sharing best practices, training, QA, and anyone wish to do pilot. It's been recommended that they submit to the committee form on ultrasound, just to review and just really share best practices and so on. I believe, I guess, is the final letter, so I don't know if that can be disseminated or it has been. Michelle was already sent out to
Yes,
everyone.
was
Yeah, it was sent out.
Really, essentially, that's it.
So the bottom line is Dr. Yes, go ahead.
One other thing is one of the, I apologize, the other thing is part of, I know Michelle's been fantastic, reminding me about technologies tag. So we're gonna do one on ultrasound devices. There's a lot of ones out there where it was familiar with Butterfly, GE's come out and new ones, several devices. So we're gonna have an open, just confirm the location, time and date. A lot of companies, so people are not familiar, some of the newer devices on the market, they're obviously a lot cheaper than when we first started. Some of us had to, those old jalopies, which on the are now they're just kind of in your pocket, a lot of AI built into it. So we're gonna have, I'm just trying to finalize the date. I'm hoping in June next.
Great. Thank you.
Sorry, I didn't-
No, thank you, Dr. Isaac. So the bottom line is the ultrasound tank wants to encourage agencies to submit pilots to try to implement ultrasound in the pre-hospital setting. And they will support with best practices and whatever is needed in order to approve and support these pilots.
Great.
Dr. Redliner.
Thanks, David. There's 2 points I'd like to add. One, I'm supportive of innovation. I think it's a great idea to kind of think about how we can innovate to care for patients. The second part, though, is about, the impact on the care that we provide, right? So if you're implementing a new device, like an ultrasound device, it's got to be clear purpose, and there's got to be like safety measures involved, right? Like, how long are you going to stay on scene to do the ultrasound in a trauma patient, et cetera. But again, all I'm saying is that I think as we build the innovation, got to make sure that
just to and understand it, I agree with you, and I think it's going to evolve. The utilization of ultrasound as technology improves, but that's what this group tag, the ultrasound tag, was discussed about sharing best practices, training QA, and kind of submitting to the tag to review. Because I think while a lot of people here at this table use ultrasound as part of their practice, it is new to the pre-hospital setting. There are some best practices out there nationally, but to your point, we just don't want it to delay care, interfere with it, and so on. It's not treatment diagnostic, but that just impacts the patient.
Great. I think that this is definitely a great letter to send out to the region to improve and increase awareness as well as interest in pilot projects. There is a state pilot project submission process. So that if we do want to do a pilot project, it would have to be submitted through that process. But I think this will definitely help generate some more interest in it. But I think that part of the pilot project process is ensuring a lot of the things that Michael just brought up in terms of ensuring that it will not, that there's a QA component as well as a not affecting or harm to care or delay of care. So I think this is great. I don't know that there's more to do than to send this out to the region.
And then to your point, we'll bring it up at the May meetings. That's the state.
Perfect. Great, thank you. Anything else, Dr. Benelli?
Thank you to the ultrasound tag committee members. They were listed over there for putting this letter together. That concludes both medical standards committee reports for March and April. The next medical standards committee is meeting on June 4th, 3 p.m. virtually. No traffic involved.
Thank you. Okay. QA/QI, Dr. Redlener.
Thank you, Dr. Schenker. We haven't met since the last, actually, we met prior to the last REMAC meeting, which was not a quorum. And so I'll just go over some of the items that we discussed at that previous quality meeting, and I'll invite Letitia Cooper, who is their New York City Regional CARES Coordinator, to give an update about where we are with CARES in just a moment. There was 4 items. One, firstly, there was a patient care restriction that we've been managing, a regional patient care restriction that is progressing through the remediation phase, and that is all set. And we appreciate all the support from partners and the committee on getting through this complex case. There are no new cases that we are reviewing at this point. The second item that we discussed was the First Watch dashboard. For all of you in the region who are part of the First Watch project, you have access to the First Watch regional data, the regional dashboard for the AHA measures that we've put together. So it's something that is, will evolve and will improve with time. You have to look at it and use it at your agency level. There's lots to discuss. I'm not going to present anything today, but we will. I think it's a useful tool to look at the stroke and STEMI measures. When we think about new projects, there's probably opportunity to go look at regional new projects, not within the scope of that AHA, the original project. But I think that we are going to focus on a few things related to stroke and STEMI, and more will come out about that over the course of the next few months. Another item that Joe Ranieri is working on is that there are state-based quality measures that will soon go up on the website at REMSCO that will be options for folks to use in the state as to do agency level or regional quality improvement. And so Joe is working with the state to kind of get that implemented. Lots of discussions and things going on at the state level related to getting those resources available for any agency that wants to use it from the State Bridge and from Biospatial, which is a data visualization tool. And then the last item was the CARES update. As everybody knows, we're moving forward with New York City CARES project. I know Letitia can give a better update on where we are with EMS agencies and with hospital systems. I know that there's been some movement. Sinai has signed on, and we are actively putting cases into the system, both on the EMS side and then following up with the hospital-based side. So it's exciting. We're about a month or so into it, and there's no major hiccups or anything like that. So I'd encourage everybody to think it through. All right, thank you.
Hello, everyone. I'm Letitia Cooper. I'm the American Red Cross New York City CARES Coordinator. I do want to share just a few updates that we have. Actually, can I? Just so you can see my contact information.
Yeah, it's an HDMI. It's the same one you used last time.
Fill the space while she's getting set up. I mean, Letitia is going to be a great contact for anyone to really to get set up on the system. She's helped our organization along with the folks from New York State level. So if there's any questions or details that you have and you need answers to, she's the person to help.
Cross New York City CARES Coordinator. Sorry about that. We have full approval from Northwell, so they are fully on board, and we are excited to begin working with them. New York Presbyterian continuously been putting in CARES data as of March, and I did an EMS training as of the 26th of March. And as you know, Mount Sinai has been doing great adding data into the system. We do want to continue talking about the data. Yeah. We want to get the wheels turning about who will be on this committee. You know, we want representation from each level, hospital level, EMS level, just so we can have a broad variety. Sorry about that. Okay. But now we have Mount Sinai, we have Northwell fully ready to go, and NYP. Any questions about that?
I mean, I think the thing that's important is that there are definitely political and barriers, and there are some time commitments of people who are involved. So I think that the more agencies and places we get on board, the better it will be, the more complete data we'll have for the region. Again, I think that once we are plugged into that, we'll be able to think about it and talk about it in a data-driven, talk about cardiac arrest in a data-driven way.
Great, thank you. Any questions for Dr. Redline? Yeah.
Can I just ask for an update on the BLS IGEL file? How many do we have now?
I think there were just 2 that had gone through that were submitted, just the Jamaica, and then there was 1 other that had been submitted.
And there's a volunteer.
It was like
Do we have
Glen,
numbers?
was it Glen Oaks or?
Yeah, no, it's Ridgewood Volunteer. We're going through the training still, so it hasn't gone by.
Don't read this.
Sorry. Okay. Anything else?
Nope, that's it. Thank you.
Thank you. All right, so Morty Lax is not here. He did make it known to David and I that the training will be in place by next week for the regional update. So that is moving along appropriately. Dr. Berkowitz is not here, so he will present the interfacility transport at the next meeting. There is no RTAC update that I know of, so we're up to the regional council update. Dr. Krupa.
Okay, thank you very much. So Regional EMS Council met here on March 26th. And I'm going to just give you a brief summary. The approved motions, there were completed applications for CFR, EMT, and paramedic courses renewals, received from several course sponsors, which were approved. The approved course sponsors are FIDNey, EMS Emergency Care Programs, and B&H Emergency Medical Training Incorporated, LaGuardia Community College of St. John's University. Steve Sasso from T-Mobile was also here, presented T-Mobile's First Responders Connecting Heroes program, really a program aimed at supporting first responder agencies with priority access to a nationwide network. I believe our website actually has links you can go to if you want to access this program. If not, we're happy to provide those links to you. Marie Diddley also gave program agency updates. She reported the following. The Office of Regional Council is collaborating with New York State and other program agencies to review the governor's budget. They have also contacted the health committee chairs of our state assembly and Senate and requested that funding be distributed more equitably. There are concerns regarding the EMS task force and the state's plan to hire additional 135 people. And we're hoping that more information will be available after the May CMAC SEMSCO meeting up in Troy. Martina Baccaroli gave the ambulance committee report. She reported on the following. There were no new transfer of operating authority or determination need applications. The security sticker tag requires an updated quote from the vendor. A template, a letter will be sent to committee members to support EMS providers being exempt from MTA congestion pricing. Copies of the bills were sent to members prior to the meeting. Michelle Clem also reported that Training Education Committee will complete the 2024 protocol update by April 1st of 2024. That's very close to now. Okay, and it'll be uploaded to the learning management system. Also, REMAC advisor will be available by the next REMAC meeting. There was no Q&I committee report at our last meeting. Marie Delia did announce that the Regional EMS Council will host the EMS Week Awards ceremony on Sunday, May 19th at Roosters on the Bay. This marks the 50th anniversary of the Regional EMS Council and Emergency Medical Services. And part of the celebration will include presenting awards to recognize outstanding contributions. Nominations for awards and award sponsorships are currently being accepted. The Office of Regional Council will resend the links for awards nominations and award sponsorships. I know I received it. Hopefully others did also. If not, let us know. We're happy to send it. There are 4 at-large seats available on the Regional Council. Nominations are being accepted now. KK and voting will occur at the June meeting. Last point, Grace Cratchell reported that multiple 911 participating voluntary hospitals are withdrawing from 911 system. This is creating a shortage of personnel. Although FIDNey EMS is training additional classes, it cannot maintain personnel necessary to staff the ambulances. During the meeting, the committee discussed the need to approach the regional correspondents to clarify the requirements for flexible working hours in the profession. Additionally, Kate, there was discussion about involving New York State Department of Health in improving hospital openings and closures. Currently, there's concern that the closures really don't take into account the impact, the loss of voluntary hospital services, and the overall impact on the EMS system within the regions and as a whole. So the next regional council meeting will be on April 16, 2024.
Great, thank you very much. Any questions for Dr. Krupi? I was gonna bring this up under new business, but since Bob already brought it up, the EMS week dinner is May 19th at Russo's on the Bay. It's the 50th anniversary of the New York City REMSCO. So all who can either participate, come, or help sponsor and support it is much appreciated.
Has there been a call? Has there been a call out yet
Joe,
to
what
sign up?
time?
The 1 o'clock.
Has there been a call out yet to sign up?
Will be open.
It's a 1 o'clock dinner? Are we in Florida?
It's the early bird, the early bird of the early.
Listen, we have to get a discount.
Very
somehow,
early.
all right? Yeah,
No, my question was about any invitations.
yeah.
Yep.
Okay. So I guess Paul is not coming because it's too early for him to eat dinner.
Early bird
It's a
special.
really, really late dinner from Saturday night.
Correct,
That's what it
correct,
is.
correct. All right, well, if you can come, we'd all like to see you, so that'd be nice.
1 o'clock.
We didn't have a meeting, we didn't have a meeting before that. Okay, CMAC update, Dr. Ravitch, please.
All right, so CMAC and SEMSCO met February 6th and 5th and 6th in Troy. Some items, the New York State EMS Memorial will be Wednesday, May 22nd at 11 a.m. Empire State Plaza. Their Vital Signs Conference will be in Rochester this year, October 16th to the 20th. The CCT level, the critical care level, as we all know, is sunsetting. The CMEC and SEMSCO voted to make that official in 2027. So there'll be a final bridge course for those that wish to become paramedics. That'll start in April of 2026. As of July 1 of 2027, the ALS Collaborative Protocol removed that level. And if you have a CC card at that time, it will be removed and you'll either be changed to an AEMT, or if you do the bridge, they'll become paramedics. Let's see, what else? The revision to EMS education regs, they were published for a 60-day public comment period. There weren't many comments received, so it's open for another 60 days, but they should be approved in May. One of the changes to those education regs is that the recertification process will move to be a 4-year card instead of 3. We expect next Part 800 equipment requirements and blood regulation changes to be open for public comment as well. As everyone knows, the most revisions were finalized and released with the education program. What else of significance? The governor's budget proposal was a big topic of the meeting. Obviously, there were changes since then in that the Assembly and Senate released their own versions. The Assembly completely removed it. The Senate largely changed it. There's no finalized budget from the state yet, so remains to be seen what comes out of that. There's a presentation by OMH regarding rollout of crisis stabilization centers. They plan to open these centers across the state. There was a lot of feedback provided to them, a discussion about making sure that EMS could access these and that it could be a primary destination for those that, didn't require an ER for other reasons. They did a lot of listening. There's not a lot yet as to how they plan to roll it out. Quality metrics was discussed. Dr. Redlener was there. There was a lot of discussion about metrics that were going to be implemented for reporting statewide. There was a discussion about data collection as well, prompted by the iGel demonstration project, and that it's difficult to get accurate data. Basically because the state has their own NEMSIS definitions, and it's very difficult to correlate that database with actual outcomes measures. So there's going to be more discussion on that. But there was a lot of questions asked about, maybe putting together some sort of data governance committee or some You have a comment? Doug? Yeah.
Successful pilot, but they're only reporting what, less than.
About 50% of the data is, yeah, missing. Yeah. So, yeah, the stuff they have data on, it's good, but it's been a struggle to get data, not just to get people to report the usage. They've done fairly well with that. It's getting the data out of the state's database has been a challenge. And then finally, CMAC and SEMSCO recognized Dr. Marshall for his 25+ years of service, having chaired medical standards for most of that time. And those are kind of the big updates. I don't know if anyone has any questions.
No question, but one issue that regarding.
Use the mic.
Yeah, no, just pull it,
you're-
just pull it. You
not
had it
pull
on.
Push
Yeah.
it again.
Yep,
Good.
you're good.
One issue that arose was regarding the transport of potential
Yes.
pediatric patients to crisis stabilization centers. And as many of you may know, the EMSC committee at the state level has been working to develop an educational program on primarily de-escalation, but a more global program on management of pediatric agitation, which, as you all know, is mostly de-escalation focused rather than medication focused. But scenarios are being developed and so on, and the crisis stabilization group was invited to participate. And it's thought that perhaps this training may be available to some of the individuals who staff the crisis stabilization centers as well. We all know that the pediatric mental health issue is getting to be very big, and so this will hopefully be a very welcome addition to the the state's mental health resources. Thank you.
Thank you.
One of the things.
Yeah.
Just Jeff mentioned the Tree of Life ceremony. I just wanted to bring up that the parties upstate was able. Regarding the Tree of Life ceremony, the parties upstate were able to allocate to one of our members who was lost last year, a New York City EMT, Peter Bojmal, and he'll be honored at this Tree of Life ceremony this year. It was a late submission and the state was very gracious in getting Pete on the list. So if anyone's on the fence about going, I suggest you do.
Thank you. Dr. Isaac, did you want to add anything to the report? You go to CMAC as well. Great. Anything else for Dr. Rabbit? Okay. Hearing none, we'll move to unfinished business. So we already spoke about the EMS week dinner. I also want to mention the search and rescue field medicine symposium, May 2nd, May 5th. Right, there you go. If you can agencies, there are discount for agencies, is that correct?
Group rates available?
Yeah.
Group rates.
There are groups coming.
Great. So please encourage your people to go. Any new business? Yes.
Just want to take a moment to recognize the BMCC paramedic students that are here tonight. Thank you for attending.
Thank you. And thank you guys for coming and participating. Any other new business? Hearing none, I will entertain a motion to adjourn.
So moved.
All right, thank you all very much.
Let's go,
and we'll
Rangers.
See you again in.
It's the most punishing thing anyone's ever done to anybody.